Welcome everyone to the first part of a three-part webinar series on pediatric genetic cancer syndromes. We are so thankful to have you all here today and are excited to kick off this series. Good evening, good morning, good afternoon from wherever you are joining us, and we are so excited to have you all here. Since this is a webinar, you will only be seeing the screen and the speakers. You will not be able to chat or provide any other information, but we are very thankful to have you all here today. We want to start by thanking our advocacy group partners who have supported us and have been instrumental in creating this webinar with us and making it a success. We are very thankful to all members of these communities who have joined us, and so we want to a special thank you to Illumina and the patient advocacy team from Illumina, who were very open to collaborating with our foundation and creating this wonderful series with us. We are so thankful that they have been able to provide all of their expertise to ensure that we are providing the most scientific and accurate information for all of you. Just a few reminders, the speakers will not be providing any personal medical advice or will not be providing any individual responses to specific cases. This is a public webinar, so please do not put any of your personal medical information that you're not comfortable with others looking at. Include any Q&A in the Q&A section that is provided in the bar below, as you may see, so that no questions are missed and all questions will be answered either live or as a response. We will also get to any questions via email if they are missed at the end of this webinar. Now, for your convenience, closed captioning and transcript is available in many languages, so it will be seen at the very bottom of the Zoom screen. Please ensure that you are clicking it and picking the language of your choice. We want to make sure this is accessible to all of you. A recording will be provided to everyone who is registered once we finish production of this webinar. We will also be posting it on YouTube, hopefully for everyone in the coming months to. With that, so excited to welcome Emily Dalton. She has been a genetic counselor for over 15 years and has been in the industry for over a decade. She is currently the Associate Director of Oncology Medical Affairs at Illumina, where she provides education and generates evidence supporting the clinical utility of comprehensive genomic profiling of tumors. Prior to Illumina, she was at Ambry Genetics, starting as one of the first field-based genetic specialists and ultimately growing to support the entire genomic science liaison team as the director for 4 years. She started her career practicing clinically at Dana-Farber Cancer Institute, our favorite, after earning her master's in genetic counseling from the Boston University School of Medicine. She still resides in the Boston area, and I can't wait to see her the next year. We are there. Over to you.
Excellent. Thank you so much, Parvati, and thank you everyone for joining. Let me pull up my slides here. All right. Can you see those okay? See them in presenter mode? All right.
Yes, ma'am.
Excellent. Great. Well, yeah, I'm so happy to be here today and talking about a subject that's very near and dear to my heart. So, as Parvati mentioned, I am a genetic counselor by training. And although now I focus primarily on the tumor side of things, so the tumor genetic testing, my background and my clinical practice is really on the hereditary side. And when I was at Dana-Farber, counseled hundreds of patients about hereditary cancer, walked them through the testing process, through the results disclosure and what that means for them and their family. And then when I was at Ambry, focused a lot more on educating the medical community at large about the importance of hereditary cancer testing, some of the advancements in testing, and just really it's a goal, a personal goal of mine to make sure that we're always increasing awareness, but also access to appropriate hereditary cancer testing. So really happy to be here today. And as Parvati mentioned, this is the first of what will hopefully be a series of 3 different webinars. So today I really think of as foundational knowledge, right? So what is hereditary cancer? Genomics in cancer, we're talking about different types of mutations, so hereditary versus somatic, different inheritance patterns, but then also understanding risk and penetrance. So really laying the foundation for the next couple of webinars where we'll really dive more into specific hereditary cancer syndromes, how the testing process works, different types of results. So we won't be getting into that today, but we'll be building upon what we talk about today in future webinars as well. So I'm not able to see the Q&A function, but by all means, this doesn't have to be me talking at you for the whole time. So if there are questions that come up, feel free to interrupt. Otherwise, we can hold all questions till the end, but I'm happy either way. So if there's something very urgent, Cody or Parvati, that you want to mention, please go ahead and do that. All right, just give me one moment. All right. Okay. Excellent. So, as you might have heard before, that cancer is a disease of the genome, but what does that actually mean when we talk about that? So, cancer is obviously a very broad term, and it's a group of hundreds to thousands of different types of diseases, but they're all caused by mutations or errors in genes that control cell growth. And it results in uncontrolled proliferation, which is another word for cell division. So our cells are always growing and dividing. That's a normal part of life. But due to all of these factors that you can see here, both internal factors, whether you're getting an error in a particular gene sequence, if there's an inflammatory response, different kinds of internal events that can happen, that can sometimes damage our DNA, damage our genes. But there's also well-known external sources as well. Of course, UV, ionizing radiation, so exposure to a lot of UV light or radiation. Obviously, environmental factors, pollutants, and carcinogens that are in the environment that we're all exposed to, some more than others. All of those sources can damage our DNA. And when that damage occurs in a gene that's meant to control cell growth and make sure our cells are growing and dividing normally and at a normal pace, when that process is disrupted, our cells can start to divide out of control. And that can really start causing these mutations, these errors to accumulate, right? If this is happening too quickly and all of our repair mechanisms aren't able to fix the errors, they can accumulate, causing the cancer to grow and develop. So most of the time, and we'll get into this a little bit more, most of the time, cancers are sporadic, meaning they're not something that's due to an inherited gene mutation. But only about 5 to 10% of the time, the mutations that can lead to cancer are inherited. And this is what we're primarily talking about today. Before we get into that, I really like this graphic because I think as a genetic counselor, we always love analogies, right? So what can we relate this very complex genetic information to, something that we all understand? So as I was just saying, there's a number of genes that are involved in protecting our cells from growing and dividing out of control and growing into cancer. And the two main categories here are called proto-oncogenes, and you can think of those as like a gas pedal in a car, or tumor suppressor genes, which we can think of like the brakes to a car. So you can imagine that if either of those types of genes have a mutation or an error that causes them to not be working properly, whether it's a proto-oncogene that develops a mutation, turning it into an oncogene that can lead to too much gas and that cell is going to divide out of control, or if it's a tumor suppressor gene where their job is exactly what it sounds like, it's meant to suppress tumor growth. So if those genes are inactivated due to a mutation, that means that there's no brakes, and again, that cell can divide out of control. So the mutations that lead to cancer can either be inherited or germline mutations or somatic or acquired mutations. And we'll go into some more specifics on the next slide. But most of the mutations that we're talking about when we talk about hereditary cancer are in tumor suppressor genes. So these are mutations that can be inherited through the family, passed down through the family. And again, it's something that is causing these genes to not function correctly and predisposing people to developing cancer. So as I mentioned, the mutations or errors in genes that can eventually potentially lead to cancer can be either germline or somatic. So if we start on the germline or inherited side, these are mutations that are present in every single cell in the body, including in the egg and or sperm. These are mutations that can cause a hereditary predisposition to cancer or an increased risk for cancer, but they can also have treatment implications because there have been some treatments that have been developed that are specific for people that have these inherited mutations. These mutations are typically detected with a specific genetic test that's looking specifically for germline mutations. These are typically sent out to large reference labs that are very reputable, that have done hundreds of thousands, sometimes millions of these tests. They're, again, specific to identify these germline mutations. They can sometimes be picked up if someone has an active cancer diagnosis and a specimen of their tissue or a specimen of their tumor is sent to the lab for evaluation. Sometimes these mutations can be picked up there, but most often they're picked up by these specific germline genetic tests. So again, they're found in the entire body, every single cell. They're typically inherited from a parent, and they can predispose the carriers to a higher risk of cancer. On the other side are somatic mutations, and these are mutations that are acquired in our cells and that can eventually lead to tumor growth. These mutations can be in all tumor cells or only certain areas of a tumor. And these mutations in particular can really impact the diagnosis and treatment of a particular cancer. And these are detected with tumor sequencing. So it's a similar technology, but different application. So again, oftentimes when someone is diagnosed with cancer, a piece of their tumor may be sent to the lab to do many different tests. Sometimes these tests are genomic tests to identify the somatic mutations, which are driving that cancer and can be actionable to target for therapy. But again, today we're focusing primarily on the germline mutations. So if we think about germline versus somatic mutations and how these lead to the development of cancer, but also how they relate to some of the red flags that we're looking for with hereditary cancer that we'll discuss later on, we can think about it in a very simplified graphic like this. So in sporadic cancer, or in general, we have two copies of every single one of our genes. So we get one copy from our mother, one copy from our father, and these are present when we are conceived and at birth. So we have two copies of every gene, and this includes the tumor suppressor genes that I was mentioning. So if we think of these two green bars as, let's just say it's tumor suppressor gene A, that's made up, but just for an example, these are our two normal working copies of our tumor suppressor gene A, and they're both working properly. We're born with two working copies. In most cases of cancer development, someone may acquire a mutation over the course of their life. Again, this could be due to an internal source or an external exposure. We often don't know where these mutations come from, but they may develop a mutation on one copy, but then they're still protected by that other copy of the gene. However, more time may pass, more exposures may happen. They may acquire a second copy or a second mutation on the other working copy of that tumor suppressor. And then you can see that cell is no longer protected by that tumor suppressor gene, and that can lead to cancer development. Alternatively, in hereditary cancer, these individuals are born with one copy of their tumor suppressor gene, whatever it may be, that already has a mutation. This is something that is typically, not always, but typically inherited from one of their parents. It's typically something that has been in their family for many, many generations. So it's not something anyone caused or did or didn't do to pass this on. It's just chance. But they may be born with one copy of their tumor suppressor gene already mutated. And remember, this is something that would be present in every single cell in the body. So it only takes one additional event or mutation to knock out both copies of that tumor suppressor gene, which can ultimately lead to cancer. And this is really why we tend to see some of the red flags that we'll discuss later on, but we tend to see younger ages of cancer, multiple cancers in the family, risks for multiple cancers when we think about red flags of a hereditary cancer. In certain rare syndromes, which some of you may be very familiar with, such as CMMRD, which again, we will get into specific syndromes in future webinars. But in some syndromes, individuals are actually born with both copies of their particular tumor suppressor gene or other gene that have been knocked out. They've inherited mutations, one from each parent. And so again, they're born with two copies, which can result in even younger cases of cancer diagnosis. But we'll get into the specifics of that in future webinars. So if we revisit the prevalence of hereditary cancer, you'll remember that only about 10% of all cancers, and this varies somewhat by cancer type, but this is a pretty generally accepted statistic. Only about 10% of cancers are considered to be hereditary, meaning that individual has inherited a mutation in one of those genes from their parents, and that leads to the development of cancer. The vast majority of cancers are what we call sporadic, meaning we're not able to identify one single cause for the development of that cancer. And most of these are a mix of genetic and environmental factors that combine and lead to the development of cancer. In about 20% of cases, we may see certain cancers that are tracking in a family. We may see families that have multiple breast cancers or multiple colon cancers, but we don't identify that hereditary gene mutation. And in those cases, we suspect there's likely more shared genetics or more shared environmental factors that are contributing to the development of that cancer. But it's again, not one thing that we can pinpoint like in hereditary cancer. So how are these mutations actually passed on and inherited? So, in the majority of hereditary cancer syndromes, we're talking about autosomal dominant inheritance. So, what this means is that one parent has, and if we're again, we think about our tumor suppressor gene example, one parent has two normal working copies of the gene, and one parent has one normal working copy and one copy that has the mutation. And again, this copy that has the mutation has been passed on in the family for many generations. So, in terms of the risk for passing it on to the next generation, there's basically a 50-50 chance that this parent will either pass on their working copy or their non working copy. And that's a new chance with each offspring. So, with each child that this couple may have, there's a 50% chance that the affected parent will pass on the working copy of the gene and a 50% chance that they'll pass on the non-working copy. And again, that's a new chance every single time with every single child. So it's possible to have 4 children without the mutation, 4 children with the mutation, half and half, 3 and 1. It's a new chance each time. And the only way to determine that is through genetic testing. Another form of inheritance is called autosomal recessive. This is less common in many hereditary cancer syndromes, but we do see this type of inheritance in certain rare syndromes. In this case, both parents carry a mutation in a particular gene. And in this case, there's a 25% chance that they both pass on the non-working copy of the gene, 50% chance that one will pass on a non-working copy, one will pass on a working copy, and a 25% chance that they'll both pass on the working copy. And again, it's a new chance each time. So, as I mentioned, because individuals with hereditary cancer syndromes in their family are born with these mutations, there are certain patterns that we look for and that we tend to see in the family medical history. One of the hallmarks is younger ages at diagnosis. And this makes sense if you think back to our little graphic with the two green bars. If someone is starting at that later point, if they're starting with one copy of their tumor, one of their tumor suppressor genes already not working, it only takes one additional event to knock out the other copy and potentially lead to a cancer diagnosis. So we tend to see younger ages at diagnosis. We can also see multiple cancers in a single individual, and these tend to be related to the specific gene mutation that they have, such as breast and ovarian cancer and a BRCA mutation carrier, et cetera. But that's another red flag that we look out for. We also tend to see related cancers across many generations in a family. And again, this is a generalization. This will not always be the case. We know family histories and families can look very different. And we know that there's often, we may not know what's in our family history, but again, speaking in a generalization, a red flag that we look for are kind of these related cancers that are tracking back through many generations in the family. And then lastly, rare subtypes of cancer. Again, this tends to be related to whatever specific syndrome or gene we're thinking about, but there are certain cancers that are very indicative of particular hereditary cancer syndromes. So I wanted to show a couple of examples, and if any of you have been to a genetic counselor, had genetic testing, you may have had your pedigree taken. And a pedigree is a fancy term for how we draw out a family history. So, to orient you, for those that might not be familiar with pedigrees and what they mean, the circles here are females, the squares are males. These two individuals would be siblings. And so the vertical line here represents a parent-child relationship. And this horizontal connector indicates a spousal or marriage or, the two individuals that are having children together don't necessarily have to be married. And so then if we go up in the generation, this would be siblings. This is this individual's mother. This is this individual's uncle and aunt, and so on and so forth. This is their grandmother. So each line is a different generation within the family. So again, we're not here to go through specific hereditary cancer syndromes in a lot of detail, but I wanted to show some examples to really highlight, again, some of those red flags that we tend to see in families that have a hereditary cancer syndrome. So these represent two of the most common hereditary cancer syndromes. So we see BRCA1 on this side, Lynch syndrome on this side. In BRCA1 families, we tend to see breast and ovarian cancer. And in Lynch syndrome, we tend to see colon, endometrial, and other cancers. But you can see here that this individual was diagnosed with breast cancer at 42. Their mother died from ovarian cancer at 49. There's a cousin here with a young breast cancer and another aunt with ovarian cancer. So we see all those red flags that we talked about. We see a younger age at diagnosis for cancer, breast at 38 and 42. We see related cancers in multiple generations. We see rarer cancers. Ovarian cancer is still considered to be quite rare. In Lynch syndrome, it's a similar presentation, however, with different cancers that correlate with that particular gene mutation or syndrome. Cody, I see you came off mute on video, so I'm assuming there's a couple questions. I'll pause there.
Yeah, thanks, Emily. So we do have a question here in the chat. A reminder, if you have a question, please put it in and we'll look at either answering it live or holding it to the end. But someone has asked if they don't have a lot of rich family history information, how do they know if they're at risk?
It's a very, very good question, and something that as a genetic counselor, as I've counseled patients in the past, that sometimes there's just a lack of information. And so, sometimes we base it off of personal history. And of course, we always try to do testing before someone is diagnosed with cancer if they are aware of their family history, but that's unfortunately not always possible. So we can base it on someone's personal history of cancer or precancerous lesions. We can, there's certain things that might not look exactly like a cancer diagnosis, but if we see people that are passing away at young ages, even if the specific cancer type is unknown, or if it's a female cancer, something like that, those are kind of some other more subtle red flags that we look for. But we also know that some families may just have a limited family history. Some families may not have multiple people in each generation. They may have, only one or two people in each generation. And in those cases, we have to just look at it with a more critical eye. And that's where I'll say it's really beneficial to meet with a genetic counselor or other genetics healthcare provider who can kind of, again, look at it with a little bit more scrutiny and try to uncover some of those potential red flags or risk factors that might not be so obvious. But sometimes there's just a lack of information. Obviously, if people are adopted and don't know their family history, there's not much that we can do with that. So in those cases, we just talk through individual patient risks and what we might be able to do.
Thank you.
Yeah. All right. So my last slide before we can dive more into the Q&A is thinking about a concept that we call penetrance. And what we mean by penetrance is the proportion of people with a particular genetic mutation or variant who exhibit signs and symptoms of a particular genetic disorder. So that's a little bit of a long-winded way to describe this, but in the context of hereditary cancer, what this basically means is that most of the time, and again, this will vary by specific gene mutation and syndrome, but in the majority of cases, if you have a particular gene mutation, it doesn't necessarily mean that you will definitely develop a particular cancer, right? It puts you at an increased risk for whatever cancers may be associated with mutations in that gene, but it's not a definite absolute, you will definitely develop cancer. So that's what we mean by penetrance. And this actually goes back to the family history as well, because someone may have a particular gene mutation, but no cancer in the family. And that could mean that people have lived their whole lives with a gene mutation and never developed cancer, or they didn't inherit it. So it's a little bit of a tricky concept to understand. And again, these numbers are generalizations. They're not specific to one syndrome, but they're representative of some of the more common hereditary cancer predisposition syndromes. So like in BRCA families, we can see up to a 40% risk for ovarian cancer and up to an 87% chance for breast cancer. And in Lynch syndrome families, you may see up to a 60% chance for uterine cancer. So the risks are certainly elevated, and this is not to downplay the impact of those risks and what it means for someone's individual care or family history, but it's just to understand that inheriting the gene mutation does not equal developing cancer. It's really considered a risk factor because although in my examples, I've talked about tumor suppressor gene A, in reality, we have hundreds of tumor suppressor genes. We have many different pathways and genetic pathways that control cell growth and cell regulation. And so there's a lot of different mechanisms that can protect our cells from turning cancerous. So while inheriting a gene mutation in a tumor suppressor gene does put someone at increased risk, there are other mechanisms that are protective, and some individuals may never go on to develop cancer. So that's what we mean by penetrance. So with that, I will pause there. That's really the bulk of the content I wanted to get through for this first brief webinar. And like I said, in the future webinars, we'll build upon that. We'll talk through some more of the specific cancer syndromes. We'll talk through the genetic testing process. I know that can be oftentimes very confusing, very overwhelming. And so we wanted to dedicate a webinar specifically to just genetic testing in general. So that's all coming in future dates and times. But I'll stop sharing so that we can have our discussion.
Thank you, Emily. I'll kick off with some of the questions that were submitted to us during registration. And everyone who is here attending live, please use the Q&A option at the bottom of your Zoom screen to add any other questions. Please come up after you've seen Emily's presentation. Emily, the very first question, how do I get my children started on testing?
Yep. So that really depends on, again, what might be present in the family and the particular gene mutation or syndrome. As I mentioned, different syndromes have different risks, and some syndromes may have risks risks for cancer that do present in childhood, or screening would start in childhood, whereas others are more adult onset. But regardless, it's a very personal decision in terms of when and how to get tested. So I would say probably the best first step, and I might be biased here, but would be to meet with a genetic counselor, because again, we are trained and our expertise is really in navigating all of those factors that go into this decision making, what it might mean to test positive, to test negative. So it's really highly dependent on a specific family situation and their values, but genetic counselors can help to navigate that. So there is actually a website called findageneticcounselor.org if you're not sure how to do that, but hopefully there's also a mechanism through your individual institution or healthcare provider.
So Emily, there's also a question asking, do we actually know all the genes that predispose someone to getting cancer?
So that's a really good question. So over the past, I'll say decade and a half, our technology for genetic testing has really exploded. And so back when I was practicing and seeing patients, we could only really test one or two genes at a time. But as our sequencing technology, the technology that actually enables us to look at the genes, as that has advanced, it's also allowed us to do more widespread testing for more genes in individual patients. Like I said, many of the larger reference labs that are experts in doing this testing have tested hundreds of thousands, sometimes millions of patients. And so to your question about have we found every single gene, I can't say yes, right? Because there's always something else that we could discover. But what I will say is that we have a very good understanding and a pretty good handle on individual genes that lead to hereditary cancer syndromes. That doesn't mean that there aren't other genetic factors that aren't a single gene mutation tracking through the family. That doesn't mean that there's not other genetic factors that are contributing to cancer development in an individual or in a family. If you remember that pie chart I showed, there's still 20% of cancer diagnoses that we call familial. We might not have one single cause. So my long-winded answer is that we have a very good understanding of most of the single gene causes of hereditary cancer, but we're still learning a lot more about other genetic and environmental factors that might contribute to cancer development.
Thank you.
The questions I think that came in alive was, does gestational age increase risk for hereditary cancers?
It does not. Nope. So this is something, again, that if you have a hereditary cancer mutation, it's likely been in your family for many generations. It's not something anyone can control, passing on or not passing on. It's like a flip of the coin. So it's like any other trait. It's something that happens at conception, and you either pass on the copy that has the mutation or you pass on the copy that doesn't. Has nothing to do with gestational age or any other prenatal factors.
Emily, this is maybe a follow-on to some of your other answers, but do we understand how the environment interacts with some of these genes?
We have an understanding of how the environment interacts with our genes, and that we know that there are certain environmental factors and carcinogens that, you name it, there's many, many out there that can cause damage to our DNA, right? We do know that. That is a separate process from what we're talking about with hereditary cancer. So what may happen is someone might, again, be born with a mutation that they've inherited from one of their parents that's been in their family for generations, and that's in all of their cells. And then over the course of their lifetime, there might be some environmental exposure, and we're all exposed to this every day. I don't want to make it sound like someone is living at the Chernobyl site, right? It's just we're all like living and breathing in the world. We're all exposed every day. So that there might be something that damages the other copy of the gene or damages some other pathway that's protective against cancer. And again, that might lead to cancer development. So it's kind of two separate processes, if that makes sense.
Mhm. Thank you.
Mhm.
Next question we had is, can hereditary cancers be prevented?
So that's a great question. So the gene mutation at the current time cannot be prevented, right? So it's not something which, well, I shouldn't say that. Sometimes if you know about it and if you're pursuing assisted reproductive technologies, and let's say a couple knows one person is carrying a particular gene mutation, let's say they're pursuing IVF or some other assisted reproductive technology, the technology does exist to do what's called pre-implantation genetic diagnosis. So you can actually select for embryos that don't carry the mutation. So it's not really preventing the mutation, right? But it's more of a selection process. But I'll say that that's obviously a very intensive process, a very personal process that's not accessible to everyone, but just the technology does exist. If we're talking about the actual cancer, right, the actual cancer development, that's a different story. And that is very dependent on, again, what gene mutation, what cancer risks we're talking about in a particular family. So I'll use BRCA as an example, just because it's one of the more common ones, hereditary breast and ovarian cancer syndrome. So if someone does test positive for that, if they do carry a BRCA1 or 2 mutation and they have an elevated lifetime risk for breast and ovarian cancer, there are preventative measures that people can take. So someone could pursue what's called a prophylactic or preventative mastectomy, so removal of their breasts, and or pursue surgical removal of their ovaries as well. So that's about as close to prevention as we come, is surgical removal of those organs that are at risk. And again, depending on what screening we might have available, in that example, we have very good screening for breast cancer that can detect cancer early. So not every patient would necessarily choose to the prophylactic mastectomy. But on the ovarian cancer side, we have very limited screening techniques. And so it's actually written into guidelines that women, once they're done having their children, once they're closer to the natural age of menopause, very strongly consider surgical removal of the ovaries, again, to prevent that cancer from developing. And that's a specific example, but again, it will vary depending on the particular syndrome or gene in a family.
And Emily, there's a question here about twins. So if fraternal twins, if one of them has a cancer, how likely is it that the other twin will develop the same disease?
So it really depends on what the situation is. So if they're truly fraternal twins, again, it's a new 50-50 chance each time. So, let's say when those twins were conceived, there's a 50-50 chance that they both have the mutation, or that they both don't, or one does and one doesn't. So if the fraternal twin also is carrying the same mutation, again, that doesn't mean that they're also going to develop the same cancer at the same age. And that's where that concept of penetrance comes in, right? So not everyone is going to have the same presentation. So it really varies.
Next question we have is addressing VUS in hereditary cancer genes.
Yes. So the dreaded VUS. So VUS stands for variant of uncertain significance. And with any genetic test, there's a possibility for the result to be positive, meaning we identified a pathogenic or positive a mutation, negative, which is a good thing in this case, meaning we didn't find anything, or VUS. And VUSs are basically misspellings in genes, but we don't know if they have any significance or impact on the function of the gene. So we have acquired a lot of data and a lot of evidence, and we put a lot of effort into classifying the variants to make sure that the results that the labs are returning back to patients are reliable and can be actionable. But sometimes we just don't have enough data, we don't have enough information to accurately, not accurately, but to classify a variant as either positive or negative. And this could be that it's a rare variant that's maybe only present in a couple of families. It could be a variant that has conflicting information. Some data, some information might support the fact that it's associated with hereditary cancer, but other data might suggest otherwise. So the labs that are doing this testing have whole teams of scientists that are just dedicated to variant interpretation and classification and curation. So while VUSs still happen, they will always happen, and they're very frustrating to patients. I get that, because they're not actionable. It's not a yes, it's not a no. So they do still happen, but typically on kind of the patient side of things, we typically don't recommend making any screening or management decisions based on a variant result, because the vast majority will end up being negative or benign, nothing, not associated with cancer risk. But they are really frustrating and troublesome to deal with. But most end up being negative, and we usually don't recommend, again, making any changes to medical management based on a variant result.
And then Emily, we have a question that just came in. So someone had genetic testing, everything came back negative, but maybe they just strongly suspect that there is a genetic cause. Maybe they have a lot of cancer in the family. You know, what should someone do? Should they get retested? Should they wait some time? Should they get tested somewhere else?
Yeah, so it really depends on when they were tested. So, like I said, back when I was practicing, the technology was very different. We were only testing for a handful of genes. Now we test for 80 plus genes. I would say most of the large, reputable reference labs that have been doing this testing for many, many years, those results I would trust, right? And again, this depends on where the testing is done. Most of the time, it's going to be done again at one of these larger reference labs that have a lot of experience. And I think clinical practice now is really moving towards these larger panels of genes as opposed to a single gene test for a single syndrome. So most people now are probably getting tested for large panels, 50, 80 plus genes. So if that's the case, if you've been tested at one of the larger reputable reference labs and you've had a large panel, there's probably not a need to do retesting or to test elsewhere. Again, those families probably unfortunately just fall in that 20% of cases where it's familial, but we just can't identify the single cause of cancer in the family. But if you were tested many years ago, or let's say your testing was only for a small handful of genes, and you're curious about whether there might be a mutation in some of the other, newer genes, then it might be something to consider. So it really depends on the individual situation.
Emily, I'm going to do a follow-up for that question of yours. When you talk about these larger testing companies, those are not the ones that we can get in the mail-in, something that we do, right? That's how you differentiate between.
Yes.
Just want to clarify.
Yes, great point, Parvati. So on one hand, more people are getting access to genetics, good or bad, we don't know. But yes, we're not talking about what we call direct to consumer testing kits where, you buy a kit, you do a spit swab, and you don't need a doctor's order. You can just send it into a company and get your results back for all sorts of different stuff, including sometimes hereditary cancer risk. That is not what we're talking about. These tests at the large reference labs I'm mentioning must be ordered by a clinician, so by a doctor, by a genetic counselor, and there's that pre-test counseling involved, and it has to be sent out through a provider. So it's not something that you can just do or pursue on your own.
And again, just because I want to make sure that we clarify, and it's not something that only you have to go to a cancer center or a big institution. It is these tests, the ones that a physician can order, are more accessible
Yes.
wherever you are located,
Yep.
right? Okay.
Absolutely. Yeah. Yep. Absolutely. It does not have to be done. You don't have to be diagnosed with cancer, of course. It doesn't have to be done at a large academic hospital or cancer center. It can be done, a lot of OBGYNs do this testing in their routine. Less so primary care, but more and more, a lot of imaging centers or endoscopy centers, for thinking about breast and colon cancer risk. So more and more we're seeing this type of genetic testing being done, in the broader medical community. It would be great if every patient could see a genetic counselor prior to testing, but unfortunately there's not enough of us. So we see who we can, but again, we're making a lot of efforts to educate other types of providers on appropriate testing and result interpretation to make sure that patients are getting the best care and access possible.
And I know you've already covered this a little bit, but again, we just got a question, and I want to make sure that everyone is totally clear. You mentioned like an 80 gene test. What is the gold standard? What should folks be really drilling down and making sure that they're asking their doctor for?
Yeah, so I think you want to make sure that, again, you're getting testing at, one of these larger labs that has been doing the testing for a while. And the size of the panel, there's not really a gold standard in terms of the size. But what I will say is that there's multiple different types of cancer in the family, or if you're very concerned, again, clinical practice is really moving more to larger panels that are assessing for multiple different syndromes. So that could be a question to ask is, are you testing me for just one or two genes, or are you looking at a broader panel of genes that might be associated with many different syndromes and cancer risks? And the reason for that is, as I mentioned, the clinical practice has really been going this way over the past decade. And the more that we test patients for these broad panels, the less, like in the past, we thought we had these very clear pictures of like, okay, this is a BRCA family, this is a Lynch syndrome family, this is a Lee-Fermini family. We had these very classic, clear pictures. But as we've tested more and more people for broader panels of genes, what we're realizing is it doesn't always match up the way we thought it does. So we're seeing colon cancer families that might have BRCA mutations and breast cancer families with Lynch. So we're seeing, that what we classically thought as classic families doesn't always happen in real life. And so that's really why, we're kind of expanding to broader testing, more inclusive testing.
And then does insurance usually does insurance usually cover this sort of testing?
Yeah, so it depends on the specific plan. And most plans have guidelines that you can look up. So they have criteria that they follow for who they will cover testing for. Some plans cover large panels, some are still more difficult to get large panels covered. But what I will say is that many of the large reference labs, most of them have kind of patient financial assistance programs that people can qualify for, so that even if insurance doesn't cover it, really they're trying to make testing as accessible as possible. So you can always check your individual insurance plan's specific criteria, but then also check with your doctor in the testing lab if financial assistance is needed.
Emily, I just want to add to that. So I've been diagnosed with a condition, then there is a different pathway we can ask for family members to be tested. Those are cheaper and more easily.
Yep. Exactly. Yep. Once a mutation is identified in a family, typically, unless there's some reason to test more broadly, you would just test for that single mutation, and that is a cheaper test.
The other two questions that came that were very interesting. Can someone have a mutation and not know it? And can someone pass on a mutation if they have never?
Yes and yes. So we actually think that there's a lot of people out there that have mutations and don't know it. And again, this has to do with the penetrance, right? So it could be due to a number of different factors. Maybe they have a lower risk mutation, right? So there's not those really, really high elevated risks where you expect to see a lot of cancers in the family. Maybe they have a limited family history. So there's fewer family members that could manifest cancer symptoms. So there's a lot of different scenarios in which someone might not know that they have a mutation. So that's very common. And then the other question was, can someone pass on a mutation even if they have not had cancer? Is that right?
Mhm.
Yes, right. So again, these mutations are present in every cell in the body, including the egg and the sperm. And it doesn't have anything to do with whether you've had cancer yourself. It's just, like I said, a flip of the coin at conception, whether someone would pass on the non-working copy or the working copy of the gene. But your own personal medical history doesn't have any bearing on that.
Emily, I wanted to thank you for taking time this evening to present with us and all of our members. I know a lot of attendees actually sent information asking if the recording will be seen because they're in the middle of their workday from different parts of the world. So we are really thankful that you allowed us to record it as well. And everyone who's here, the next webinar in this series is going to be commonly seen predisposition syndromes, in which Emily is going to talk more in detail about some of the more common conditions, well, in the 10% and the 20% that Emily has talked about today. This is the code to register for everyone who has attended this webinar. We will also send you a follow-up email with a survey. We would greatly appreciate you participating in that survey. That will help us continue to provide these engaging webinars for you and also give us feedback on what we can do more in the next series. Thank you, Cody, for joining me in making sure that we answer all of the questions. I see a lot of hearts and claps coming along, Emily. So thank you for being here today, and thank you everyone for joining in. Again, I'm going to leave the screen on for just another minute. So if you want to scan the QR code to register for our next webinar, it is here. A recording of this webinar will be posted on my email to all of you. Thank you once again for joining.
Thank you all so much. It was my pleasure.